Thank you everybody for joining us this afternoon. I'm delighted to introduce you to two of our team members at Lurie Children to talk about POTS. I am Julie Kalkbrenner with Lurie Children and I'm a physician liaison. I cover the west and northwest suburbs. And today I would like to introduce you to one of our nurse practitioners, Jillian Myers, and one of our cardiologists, Dr. Jarrett Linder. Thank you. And they're going to talk to you about POTS. If you do have any questions during the program, please don't hesitate to write them in the question box on the right-hand side of your screen, and we'll be able to address those after their discussion. Thanks.
Are you able to see our screen?
Yes, we are.
Okay, perfect.
Great. Good afternoon, everyone. We're going to be talking to you about POTS today. So without further ado, here we go. So we have no financial disclosures. We're going to begin today just talking about our agenda, which is going to include defining postural orthostatic tachycardia syndrome, or POTS. We're going to briefly discuss the epidemiology of POTS, review how to diagnose POTS, outline our program for you and how we like to manage this, and finally, how to refer patients to our program. So importantly, I'd like to start off saying that POTS is a diagnosis of exclusion. So therefore, in order to make a diagnosis of POTS, patients have to meet the following different criteria, but in the absence of another etiology for these findings. So the criteria include excessive orthostatic tachycardia, which is defined as a sustained increase in heart rate above 40 beats per minute in adolescence when changing from a position, typically going from supine positioning to standing positioning. Additionally, they have to have an absence of a change in terms of their blood pressure. And so I wanted to review for you guys what orthostatic hypotension is. So when you go from a laying down position to standing position, and you have a change of greater than 20 millimeters of mercury, a change of greater than 20 millimeters of mercury, or a drop in your diastolic blood pressure of 10 millimeters of mercury, that's considered orthostatic hypotension. And so if you have those findings with an increase in your heart rate, then hydration would actually be the typical treatment pattern. So you need to have an absence of having low blood pressure. And then finally, chronic symptoms for these patients, which means that they have symptoms of orthostatic intolerance lasting greater than 3 months. So as POTS is a diagnosis of exclusion, I think it's really important to think about a broad differential diagnosis. So in my mind, most importantly, we need to rule out serious causes of recurrent syncope. As a cardiologist, I typically prioritize ensuring that there's no evidence of cardiomyopathy, pulmonary hypertension, coronary anomalies, or any underlying arrhythmias. And so most of our patients that come to our clinic get screened, especially if they have recurrent syncopal events, with an echocardiogram, an EKG, a Holter monitor, and an exercise stress test to ensure that none of these other pathologies are existing. Not listed on the slide, but I think also very important to consider are thyroid abnormalities, either hyper or hypothyroid. Additionally, anemia and vitamin D deficiency. Although these findings may not completely resolve symptoms that the patient may be presenting with, treating these underlying conditions can help patients feel significantly better with more straightforward treatments than treatment for POTS. So what does our patient population look like? So the literature seems a little bit discrepant in terms of the numbers of patients that are actually affected by POTS, reporting between 0.1% to 1.0% of the population inside the United States. However, among teenagers, we know that it's about 1% of our population that are affected. The onset of symptoms tends to occur between 12 and 15 years of age, and 85 to 90% of those teenagers tend to be females, so definitely a large female predominance. More than half of our cases are preceded by a severe acute viral illness, which can include novel coronavirus infection or vaccination against COVID-19. And other triggers typically include injuries, especially concussions or surgeries, and in some cases, even puberty, especially menarche or even growth spurts, we've had complaints starting. So I wanted to take a moment to talk about POTS and long COVID. We believe that there is some overlap between these different syndromes that have been described, and likely there's a dysautonomia in patients with long COVID symptoms. These symptoms tend to include cardiac complaints such as palpitations, chest discomfort, shortness of breath, neurologic complaints with orthostatic intolerance, headaches, sleep concerns, paresthesias, brain fog, and then generalized symptoms including fatigue, general pain, muscle or joint complaints, and rashes. Again, patients have to have symptoms for greater than 3 months, considered chronic, in order to meet the orthostatic testing requirements and to have a positive test for POTS. So what causes the symptoms of POTS? Why do we see this happening? So in patients, we know that gravity is involved in pulling 20% of our circulating blood volume to the lower extremities when we change from a laying position to a standing position. In response to the decrease in circulating blood volume, there is blood vessel constriction, which can result in several organ systems being involved. Additionally, the heart rate increases to preserve our cardiac output, which is directly related to heart rate and stroke volume. As the volume returning to the heart decreases, the stroke volume within the heart itself decreases, and to preserve the same cardiac output or amount of blood that the heart's able to pump, the heart rate actually increases as well. POTS is theorized to be caused by an exaggerated autonomic nervous system with increased blood vessel constriction and increased heart rate response to these changes in circulating blood volume that I just mentioned. Again, when a patient goes from a supine to standing position, blood pools in the lower extremities. This causes peripheral vasoconstriction in different organ systems. These systems involve the brain, the lungs, the abdomen, and can often explain a lot of the symptoms that we describe. And then additionally, there are baroreceptors that we know about in the carotid arteries and the aortic arch that recognize this decrease in circulating blood volume and actually cause an increase in the heart rate. This is another visualization of this process with the POTS heart rate diagnostic criteria mentioned in the top corner. A sustained heart rate response of greater than 40 beats per minute when going from supine to standing positioning, as well as multiple orthostatic symptoms, and an appropriately maintained blood pressure is how the diagnosis of POTS is made. There have been several different classifications of POTS described. Each type typically refers to the predominant symptoms affecting the patient. Many patients think about these, or many people think about these subtypes of POTS as distinct entities, which is visualized in Figure A. In practice, we have found in our clinic, as well as in this paper by Arnold and colleagues, outlines that Figure B is more appropriate for a lot of our patients, which really represents that there's much more overlap in terms of symptoms between the differently described subtypes. We typically ask patients what their top 3 complaints are, and that helps us focus on the symptoms for which we guide our individualized management for our patients. And so we don't really put them into each of these buckets, but more sort of focus on what their predominant symptom or concern is and really try to work on managing that. So as we know, POTS can affect multiple different organ systems. So from a cardiac standpoint, there's tachycardia, dizziness, lightheadedness, pre-syncope, syncope, chest discomfort, shortness of breath, exercise intolerance. From a neurologic standpoint, we know that there's often complaints of headaches, brain fog, sleep complaints, temperature instability. From a GI standpoint, we know there's nausea and abdominal pain, and often even abdominal tenderness on our examinations. Generally, many patients complain of chronic fatigue and pain as well. And lastly, mood is often affected, and many children are seeing or should be evaluated by a psychologist or psychiatrist to help with these chronic symptoms. So this article by Vidya Raj describes how the chronic symptoms of POTS can often result in anxiety and mood disorders. Many children are often misdiagnosed with primary generalized anxiety or a primary mood disorder such as depression. However, with treatment of POTS, these symptoms can often get better and they can start feeling better. The other thing that I would mention is that this article talked about how there's actually not an increased predilection for patients with POTS to have these underlying disorders. It actually seems like it's a similar rate that you see them among all teenagers in comparison to teenagers suffering from POTS. So now I wanted to switch gears and I wanted to have Jill Myers, our nurse practitioner and experts within our POTS program to discuss the management of POTS and kind of how we manage POTS here at Lurie Children's.
Thank you. So as Dr. Linder mentioned, we do, at the initial evaluation, we have patients undergo an EKG to assess for a persistent underlying arrhythmia. We complete an echocardiogram to assess for structural heart disease. We complete the orthostatic vital signs or our bedside tilt. We don't tilt table in our clinic. We actually find we can get the same results from doing the bedside tilt without putting patients through a tough study that's not super cost effective. We also complete blood work to rule out anything that could potentially mimic POTS. So complete blood count, metabolic profile, thyroid studies, ferritin, and a vitamin D. And then most of our patients go home with either a 24-hour Holter or a 30-day monitor just to rule out arrhythmias or conduction issues. When our patients come into clinic, they typically look like example A. They feel pretty miserable. They've seen multiple providers before they get to us, about an average of 6 or 7. So when they stand up, they have significant blood pooling in their legs, but otherwise their physical exam is unremarkable. In our program, we tend to heavily focus on lifestyle modifications as our initial management. So we really focus on getting the patients moving with exercise, working on hydration, and optimizing nutrition. And then patients are encouraged to consume water and sodium chloride to increase osmotic pressure and keep the fluids in the intravascular space. Expansion of intravascular volume will help compensate for intravascular hypovolemia and orthostatic cooling. And consensus-based guidelines have recommended drinking 2 to 3 liters of water a day and increasing salt through dietary interventions when possible. If patients are unable to do that, we do recommend electrolyte tablets or salt sticks. And usually we try to aim for anywhere from 8 to 12 grams of sodium a day. So there's obviously some challenges that come with oral rehydration. Approximately 69% of our patients with POTS have chronic, moderate to severe associated GI disorders that may limit their ability to ingest fluids and salts. Many also have gastroparesis, irritable bowel syndrome, recurrent nausea and vomiting, and other disorders that make sufficient oral intake difficult. I want to talk a little bit about IV hydration. We get asked this pretty frequently. In our clinic, we don't use it as a chronic treatment just because of the risk of access issue and infections. It is considered a second-line rescue therapy for short-term decompensations or flare-ups, as it generally only improves symptoms for about 24 to 48 hours. And we do use it as a bridge to really get patients up and running and getting back to physical activity and back on that management that we talked about in the beginning. There have also been several studies that report short-term IV hydration, and they have shown that symptomatically it improves symptoms in these patients. It also decreases their heart rate and prolongs time to faint for many patients. We also work on optimizing nutrition. We really focus on getting real food in the diet. We avoid processed foods, junk food. We also avoid patients skipping meals, especially with the teens. We see that they often skip breakfast, followed by skipping lunch because they don't like the school lunch. And obviously, not having 2 meals a day can exacerbate symptoms. We also really focus heavily on exercise. Many of our POTS patients avoid exercise altogether due to symptom exacerbation during and following activity. And we found that pediatric patients often have an excessive increase in heart rate and generally lower peak oxygen consumption with exercise, suggesting a lower cardiorespiratory fitness. There have been many studies that looked at exercise in the POTS population. This study by George et al., they actually enrolled 251 patients. They did a 3-month training program with mild to moderate intensity strength training, and they also increased salt and water intake. And they found that 103 patients in the training program actually had complete resolution of symptoms, which was 71%. And so evidence suggests that physical deconditioning is one important contributing factor to POTS. To address this, our POTS team created a sustainable 12-month exercise program. And as part of our exercise program, patients come in and have a cardiopulmonary exercise stress test to assess functional and aerobic capacity while observing hemodynamic and rhythm responses during exercise. After they complete their exercise stress test, they meet with our exercise physiologist, and they have an individualized exercise prescription that is meant to be done at home in the comfort of their own home with the exercise equipment that they have available. We focus on aerobic exercises and also resistance training. And we really look at what's their current status. When we see some kids, they're completely bedbound, they're in a wheelchair. We see other kids who are up and moving around, and we see some kids who are active and would like to increase their activity and get back to sports. So when we start our prescription, we really look at what level they're at. We focus on either getting them upright, so walking, swimming. We use a recumbent bike in some kids who are unable to get upright, or a stationary bike in kids who are unable to get upright. And we really focus on consistent amount of activity every day. We use the Borg scale of perceived exertion to tell them at what level they should be exercising rather than heart rate monitoring. And that tells us how it actually is, it's how difficult they feel. So we try to aim for anywhere between 11 to 13 when they're moving. So they should be having a little, their breath should be a little bit harder. They shouldn't be able to hold a conversation. They should be a little sweaty when they're doing that, and their heart rate should be up. We also focus on resistance training as well. Many patients, we start with seated exercises, often for the first 3 months, and then we progress them to standing exercises from month 3 to 6, and then we usually individualize a prescription beyond that. Many patients actually start with the standing exercises, and then ones also we do individualize completely. But this is an example of our month 1 seated exercises. As you can see, this is our exercise physiologist, and she's actually doing a modified knee plank, and then one of our other exercise physiologists is doing a straight leg raise with a resistance band, which would actually be month 2. Other lifestyle recommendations include elevating the head of the bed about 4 to 6 inches at night. This promotes volume expansion and reduces nocturnal diuresis. We also work on counter maneuvers with these patients, especially when they're symptomatic. So if they're symptomatic at school, we try to give them techniques so they don't pass out in front of their friends or feel like they're going to pass out. We also have them avoid predisposing conditions or triggers. So heat is pretty common, hot showers. We usually recommend doing cooler showers and showers in the evening, as many of our patients tend to be most symptomatic in the morning. Many of our patients also have poor sleep hygiene, so we really try to work on that. And then we try to minimize stress as best possible. We also recommend compression stockings or leggings. In terms of leggings, we usually recommend stockings. We usually recommend 20 to 30 millimeters of compression. It does help reduce venous pooling, although we found that often we have poor adherence from teenagers. And this is a quick study that actually looked at compression in the POTS population. And they did find that abdominal and lower body compression did reduce heart rate and improve symptoms during a head-up tilt table in adult patient with POTS. The literature is not there in the pediatric population, but we do try to recommend compression when appropriate. Medications. So initiating pharmacological treatment is not always advised, as this reinforces the expectation that a medication will reverse or cure the disorder. That's really important with this population. And we do not recommend starting medication until hydration, exercise, and nutritional changes have been both initiated and maintained. Many of our patients do not tolerate medications or are left with continued symptoms after starting the medication. And when we see patients in clinic, we often address their predominant symptoms. So we'll often ask their top 3 symptoms in hierarchical order. And then we really try to target what symptoms are bothering them the most. So if patients are primarily complaining of tachycardia, our first line therapy is often a beta blocker. So we use propranolol most frequently. We will also use atenolol and metoprolol. Beta blockers reduce standing heart rate. It improves exercise capacity and also will improve symptom control. Some of the common side effects that we see with beta blockers include fatigue, mood changes, and issues with sleep. And then we also use a medication called ivabradine, which I'll talk about a little bit later, as our second line treatment in patients who don't tolerate beta blockers or if the beta blockers drop their blood pressure. And then if patients are complaining of hypovolemia or we're seeing them with low blood volume, we do use fludrocortisone. It's a mineral corticoid analog that promotes sodium reabsorption. So it helps patient hold on to salt in water. It is potassium wasting, so we often have to check blood work on these patients, and sometimes we'll have to replace their potassium levels. It also can increase blood pressure. So we often find kids who faint pretty frequently when they stand up. They do respond really nicely to fludrocortisone as it helps support their blood pressure. And it can exacerbate migraines in some kids, and many of our patients do have headaches, so we do avoid it in that situation. I talked a little bit about IV fluids earlier. Again, that's a second line rescue therapy for these patients. And then patients who have significant venostasis upon standing, we do find that midodrine works really well for them. It's a peripheral alpha-1 adrenergic receptor agonist. It's a direct vasoconstrictor, so it enhances venous return, cardiac preload, and stroke volume. And again, it works really well for patients who have significant venous pooling or have really low blood pressures. The issue with it is that it can cause a lot of side effects, so numbness and tingling, and can cause supine hypertension as well. It has to be given 3 times a day, and the patients have to be upright when they take it, which is hard for a lot of these patients. This is a study that actually looked at propranolol by Raj and his colleagues. So they did find that low dose propranolol up to 4 times a day was really beneficial for the POTS population. And they looked at higher doses once a day, and they found that higher doses once a day actually have been ineffective in controlling symptoms. This is another study that actually looked a little at ivabradine. So ivabradine was found to slow sinus rates without impacting blood pressure, and it doesn't tend to have that same side effect profile that beta blockers do. So we do use it in our patients. It is an alternative to beta blocker therapy. The one issue that we found is that it tends to be pretty expensive, and that insurance doesn't always cover it. And it works really well for some patients, and it doesn't work great for others. From an outcome standpoint, we do find that with relatively early intervention in cooperation with lifestyle changes, improvement may occur within some of these kids within months. And I do find that the majority of our adolescents actually tend to outgrow these symptoms by the time they're in their early 20s, so about 20 to 21. And most of our patients, as they get further along, can report that they can predict changes in sleep or activity and actually predict when they'll feel worse or have flare-ups. And flare-ups are pretty common in this patient population, especially with viral illnesses, surgery, stress, or poor sleep. Again, in terms of referrals, lifestyle modifications should be recommended at the onset of symptoms, with early referral for a more thorough evaluation if necessary. Again, we really we recommend increasing fluid to about 3 liters a day, encourage exercise as tolerated, and optimizing nutrition, and really avoiding pharmacotherapy until lifestyle changes have been started and initiated, and please refer prior to starting medications. In summary, first-line therapy should include non-pharmacologic management with optimization of hydration, nutrition, and exercise. And initiating pharmacologic treatment is not always advised, as this reinforces the expectation that a medication will reverse or cure the disorder. Medications may be appropriate for patients who continue to experience symptoms despite lifestyle modifications, and we do use them in our clinic. And with early intervention and lifestyle changes, significant improvement in symptoms can occur within months. Thank you.
Thank you, Jill and Dr. Linder. That was excellent information. Certainly a wealth of tips to pass along to our primary care physicians. We actually have several questions. I'm going to start with one I think probably goes to Dr. Linder. If you can just repeat the orthostatic hypotension definition, please.
Oh, sure. Let me go back in the slides, as that might be helpful.
Oops. We might, let's see.
I'll turn you back into the presenter.
Thanks.
Oh, thank you. Can everybody see?
Yeah.
Okay, so orthostatic hypotension, oh, hold on, let's go to show my screen. So orthostatic hypotension is defined by a decrease in systolic blood pressure of greater than 20 millimeters of mercury, or a decrease in diastolic blood pressure of greater than 10 millimeters of mercury when a patient goes from a supine position to a standing position. in order to do true orthostatic vital signs, you typically need to have a patient laying down for at least 10 minutes before you start this assessment. And typically with orthostatic hypotension, you see that drop immediately as soon as you go from a supine position to a standing position. In the case of POTS, you have a normal blood pressure and your blood pressure does not change very much. You have a very exaggerated change in your heart rate with that change in positioning. And what's very interesting about it is that it continues. So whereas, somebody may be relatively dehydrated, still have an appropriate response in their blood pressure, maintenance of their blood pressure, usually within a few seconds to minutes, your heart rate will come back down again once your body adjusts to that change in circulating blood volume. But what happens in POTS patients is that this is a sustained response that continues to happen to them when they're in standing position.
Okay, thank you. Hopefully that's clarified the question. Here we have another one. What do you think, if any, is the relationship between POTS and ME, CFS, and long COVID?
Yeah, we're not sure. We are definitely seeing some long COVID patients in our clinic who are experiencing POTS-like symptoms. We are seeing a few patients who have been diagnosed with chronic fatigue pretty recently. So I'm not sure. There definitely is a correlation. We just don't know what it is yet.
Okay, still.
The only thing that I would add to that is that we definitely know several patients who historically have had triggers that have been a pretty significant viral illness that they've had before. And so I wonder if it's not a similar trigger for some of these patients, and this truly might be POTS in some of these individuals.
Interesting. Okay, and then I just had a couple comments from a provider. One is B12 deficiency may lead to POTS. I'm not sure if you can comment on that one.
Sure, we do check B12 levels in the pediatric population that we see in the POTS clinic. It's very rare that we find low B levels, so I'm not sure if that's only in the adult population, but it is something that we do screen for.
Okay, all right. And do beta blockers, have you found that they possibly exacerbate the hypotension?
It can. So we obviously would not use them in patients who are hypotensive. We monitor pretty closely in the patients that we start the medications on, but that is a reason to avoid it. And often on those kids, we will go right to ivabradine for symptomatic control because it doesn't tend to drop the blood pressure the same way that beta blockers do.
Okay, all right. And then going back to the hypotension, what is the change in pulse that you start to worry about things?
So again, the diagnosis is a heart rate increase of greater than 40 beats per minute. And so that is typically what we use. However, that being said, I generally, POTS is postural orthostatic tachycardia syndrome. So if somebody is an athlete and maybe has a resting heart rate of around 50 or so, and if they stand up and transiently have a heart rate elevated to around 90, the definition for true tachycardia is greater than 100. And so typically, most of our patients have to have a heart rate greater than 110, I would say, in order for us to really start considering the diagnosis.
Thank you. I think that wraps up our questions. Thank you for the questions. Always adds to the program. So I just want to thank Jill and Dr. Linder for participating today in our discussion on POTS. Both of them have contact information that is indicated on your screen right now. Their phone numbers, email, and Epic in-basket messaging are all options for you. We also have the Lurie MD line, which is available to you if you wanted to do a quick consult with it's a physician-to-physician line. So I wanted to thank them both for participating today. And please look at our Lurie Children's Heart Center website for further information. We have 2 more in our speaker series for the Lurie Children's Heart Center. Those programs are tomorrow. Dr. Carr will be presenting on COVID and the heart, and Dr. Koenig will be presenting on heart murmurs. So these sessions are all being recorded, and the copies of the recordings will be sent out to you probably Thursday or Friday. I just want to thank everybody again for participating today and we hope to see you tomorrow. Thank you.
Thank you.
Thanks for having us.
Thank you.